Great.
It said no.
Yeah. So just to be clear, Ed Miller is here in person. He hopped off, so we don't have a little doubling of the sound. Thanks for joining. My name is Michael Danielewicz. I am the director of our Pride Care at the Jefferson Center for Healthy Aging, our practice for primary care for LGBTQIA older adults, and by that I mean 55 plus. I am an assistant professor in the divisions of geriatric medicine and palliative care here at Jefferson. And today I'm going to be talking a little bit about equitable, safe, and competent care for our transgender older adults. So we'll talk about why it's important, some of what the specifics of care are, and I am open to questions at any point. So feel free, stop me at any time. If this would work, that would be nice. Oop, give me 1 second here. Okay. Ed, I think somebody is not muted because I hear myself. Hold on 1 second. There we go. All right, so we're going to start off with a brief review of why is this important? What do things look like for our trans community members? Talk about common questions about gender affirming care as it comes to aging. We'll go into a little review of screening, long-term care, and some of the challenges. And then some of the issues that come up around serious illness and end-of-life considerations. So again, stop me at any point. The reality is that trans folks have been not just underserved, but actually actively discriminated against by healthcare. And in some cases, this is still true. Some of these studies are really old, but as far back as 2005, which isn't really that far in the past, a third of trans patients who were surveyed in this area had no regular doctor. Significant number reported needing to see a doctor, but not being able to afford it, fearing things like discrimination in employment, discrimination in a variety of settings. We know that health issues are more common, partially because folks have not been able to access that equitable care. And that in part because of all of this, in part because of the stress of a lifetime discrimination, mental health concerns are very real amongst our trans folks. Not because they're trans, not one of the things that drives even part of their trans identity, but largely because of the stigma and discrimination that they face. So we know, it's been pretty well studied, that trans older adults are reporting both worse physical and mental health than their cisgender counterparts. And as recently as 2011, 1/5 of those folks surveyed were reporting being refused care by their healthcare providers, which in some ways blows my mind and in other ways sadly does not. Even back 13 years ago, 50% of patients were having to teach their providers, their doctors, nurse practitioners, and PAs about transgender care. So what you have from the sum of this is a group of folks who really live with this fear that their needs may not be met, whether it's the basics of medical care like hormonal care, whether it's personal care and having their needs met on the daily basis as far as the things that they need to do to take care of themselves, or whether it's other aspects of general medical care. So this is a study done back in 2019 that looked at what are the major concerns of transgender older adults. And in this study, I think they define that as 55 plus. So what are trans older adults actually worried about? And you'll see the general trend here is a loss of independence. Because we have not been good as a system, as a society at actually caring for, reaching out to our trans patients, a lot of folks in these communities have developed their own care networks and their own ability to care for themselves. That's pretty remarkable. So as folks age, that fear that you might lose the ability to care for yourself, that you might have to go into a nursing home, that you might even lose control of your gender identity or sexual or gender expression after death. These are all really very big concerns of trans older adults. In addition to some of the things that I've always mentioned, like the ability to continue hormones. A lot of folks are, as they age, end up in places and with providers who do not feel comfortable with hormone therapy. And I am here to say that that is total BS, because that should not be a thing. Not that people don't experience it, but they should be able to, everyone should be able to access the medical care that they need. So you see some of these concerns here. Now, back in 2020 in my practice, apologies to those who saw this talk last year, it's fairly similar. We actually looked at a survey of primary care providers and staff at a large urban academic medical center, so right here in Center City. And the reality is that although people feel pretty comfortable, and by this I talk about providers and staff, feel pretty comfortable using appropriate pronouns or communicating respectfully, when it comes time to actually provide some of those necessary medical services like hormone replacement therapy, folks' confidence was a lot lower. A lot of different folks put comments in talking about how their staff were concerned about some of these issues, that their comfort level of both the providers and staff were different and not always in favor of the providers. People want to feel comfortable doing things like sexual history or screenings, but don't always know how to approach this to their trans patients, which is part of kind of the cisgender heteronormative way that we train in medicine. Until recently, we didn't have the appropriate tools to even document gender and identity in our medical record. Fortunately, Jefferson worked very closely with our medical record provider to actually get this updated, which is a huge relief and takes a while to get going. So, major societies, including the one that I belong to, the American Geriatric Society, are devoting increased attention to trans older adults. There's been a significant increase in research and in financial actually grants towards studying and working with trans older adults. Now, that has not necessarily translated everywhere into these safe, inclusive practice settings, but work is ongoing. I mean, obviously I'm biased. I love my own practice. We are doing really good work, I'd like to think, but there are a lot of places in this city and in this region on both sides of both of our rivers that are doing really great work to be more inclusive and to outreach to our potentially vulnerable neighbors. So with that said, I am approaching this as a geriatrician. I take care of folks 55 and older. And a question that I get a lot from trainees, from patients themselves is, am I too old for gender affirming therapy? Is this going to be harmful? So I want to really approach that a little bit today. The reality is that technically any primary care provider can do gender affirming care. Technically, the day-to-day of prescribing hormones is not incredibly difficult. It's the support around it. It's knowing how to counsel people. It's knowing how to talk to people about what to expect, what not to expect, what side effects can come up, and how these medicines interact with other medicines. The good part that I will say is that I have a few medical students who I talk to, one of whom's here in the room today. And I think this is going to change as people go through their medical education. I really do. I think that as this goes more into the realm of general medicine, people are going to feel more comfortable doing this in a variety of different settings. So for folks who have questions about gender affirming care, or for folks who may have to unfortunately be doing some of that provider-based education, where you all in this conversation are actually out there talking to your providers, this is one of the major resources that we use. The University of California at San Francisco has this amazing guide for transgender care. And it was first published back in 2016. It's undergoing revision right now. And this has pretty much everything that one could need to know. So if anyone on this call, obviously you don't need to tell us anything, but if anyone on this call is considering gender affirming care, is on some of these things, has questions in addition to talking to your provider, I encourage you to check this out. So a really common question, like I said, is there an age, a specific age, where gender affirming hormone therapy has to stop? And I think those who've come to my talks before know that my answer to this is absolutely not. Age is a number. Another common question is it ever too late to start? And again, the answer is no, it is not. age is just a number. Now, when I think about hormone therapy, I think about two different types: feminizing hormone therapy and masculinizing hormone therapy. There are a lot of in-betweens here, but when I think about feminizing hormone therapy, I am thinking about folks who are trans women or trans non-binary and who are looking for more feminine characteristics, feminine. The reality is, again, this has not been well studied until fairly recently, but at this point, there is really, the major societies throw up their hands and say, we don't have evidence to say this gender affirming hormone therapy should continue or be stopped. So I really approach this with my patients on an individualized basis. If a person has undergone what we call gonadectomy, so that can involve orchiectomy or removal of the testes, you may consider discontinuing hormone therapy around age 50. Now, that is a pretty weak recommendation and not one that I see done often in my trans older patients. Most folks get into a pretty comfortable regimen with their estrogen and with their spironolactone, which is a testosterone blocker. Now, again, individualized discussion. If we're starting therapy in older adults, again, over 55, you may find that the changes that folks desire are slower or that they may not occur as prominently as we may have hoped. Theoretically, estrogen and its derivatives may have a higher degree of adverse effects due to some of the other medical conditions that folks live with. But again, that's why it's important, I think, for gender affirming care to move into the primary care realm, because as a primary care doc, I at least have an idea of what else my patients are dealing with. So that is not to say that we cannot do these therapies in folks with other medical conditions. We just have to weigh risk and benefit and have really open discussions about that. So the overall recommendation here is that we use an individualized approach. Now, when it comes to masculinizing hormone therapy, those who are often the most frequent one that I see is testosterone. There is, again, no age limit for testosterone therapy. People ask all the time, well, I've developed some degree of heart disease. What does that mean for my testosterone? And again, it means that we have to balance risk and benefit. That means if somebody has unstable heart disease where they're having consistent chest pain when walking up a flight of stairs, we may need to back down or even stop therapy. But again, we have to talk about this with everyone. You're going to be following the same labs that we would follow in somebody who's 20 and doing this. Depending on goals and expectations of folks, we sometimes talk about backing down on testosterone therapy around what we consider the usual age of menopause for non-trans women. Now, what that means is generally in 50s to 60s, as hormone levels change, we may be able to stop testosterone or go down on the doses and not see a regression of the desired features. But there's a but there. When we stop testosterone, we almost always see a change in terms of muscle mass, in terms of body hair, and in terms of sex drive. I think there's a question there. And I will get back to that one in a moment. So actually, I'll answer this now. So there's a question out there. Can you specify what conditions could be for stopping hormones? MFT, I assume you're talking about trans women there after 50 years old. So some of those conditions can be severe liver disease. A lot of the oral estrogens or even topical estrogens have some degree of processing through the liver. There are some, that one's a relative. That one we can really work with, and I can adjust the formulations. I can give other avenues of getting the estrogen. The ones that really become harder stops are when people have what we call estrogen sensitive cancers. So some of those can be breast cancer affects people with two X chromosomes and an XY chromosome. Some of those breast cancers can be triggered or worse, not triggered, sorry, is not triggered by estrogen, can be worsened in the presence of estrogen. Now that's a very, very small subset. The other things that we have to be aware of specifically when thinking about estrogen levels, people who have some level of heart disease or cardiac disease, estrogen can have impacts on that. The things that we have not seen that I get asked a lot about in my trans women are, does estrogen increase the risk of stroke? And that we have actually not seen. Part of that might be because the data isn't out there, but there is not any evidence to suggest that we should be using that. So this is the other question. Is your data about preoperative trans women? And so the answer to that is yes and no in different ways. So when I talk about some of this, I don't assume that every one of my patients is going to have surgery, especially some of my older adults, because obviously the way that folks choose to, where folks' gender identity and where their expression meet can often vary patient to patient. So when I think about this example with gonadectomy, with orchiectomy, I would consider that to be somebody who has had a surgical intervention. So the data is really mixed, admittedly. What I would say is that folks who were assigned male at birth, folks who were assigned female at birth, and who still have the organs that they were born with, the calculus can be a little bit different in that we may need or we may want to consider continuing hormone therapy in that setting to prevent any kind of gender dysphoria or regression of desired change. So any more questions? These are really, I always appreciate these questions and this participation. Exactly. So somebody pointed out that 2 of the folks present have had surgeries and have over 50 years ago. And so I do not want to make a generalization that most of my patients have not or have. I see all ranges. I've seen folks who've had their gender affirmation surgery again 30, 40, 50 years ago. I also see folks who are just kind of coming to words to describe their gender identity. And I think one of the things that's really exciting from my work is finding ways to help people explore that when they really haven't had the words or language for it for years. We're going to talk more as we get into this next section too, as far as screenings. Some of this will be related to what organs folks have and what types of gender affirmation surgery has been done in the past. So with that said, the general idea behind cancer screening in any adult, whether you're trans or not, is that if an individual has a body part and meets criteria for screening, we should be offering some kind of screening, regardless of if you're on hormones or not, regardless of gender expression and identity. That said, we have to do this really carefully in medicine because a lot of folks who are trans may not feel comfortable talking about those organs or talking about it with a provider because of past experiences. So when we think about cervical cancer screening, the most common way that folks have experienced this is what is known as a Pap test or a Pap smear. Current guidelines recommend these screenings through age 65. Some trans men still have a cervix. That's kind of a no-brainer to folks who are in this audience. And theoretically, at least, and practically, should be screened. The rates are lower. And the reality is, 1, because sometimes folks don't feel comfortable, and 2, we are not always offering those screenings. So we do know that trans men who have a cervix have a higher risk of what we call inadequate sampling and lab errors due to labeling error. Namely, as our record systems catch up with appropriate names, pronouns, and sex and gender on the forms, we're sometimes getting these things kicked back. Well, why is a man having a PAP? Fortunately, I think we have worked out, at least in this system, quite a lot of that. So I have not seen a lot of that happening in Philadelphia recently from the lab end. The thing that I want to say for folks is that for trans men, the idea of undergoing a pelvic exam can be really unpleasant. And so what I encourage, if there are any folks out there who are thinking about this and are saying, I really do not want to have that done, there are a couple of other options. One is this idea of self-PAP. A lot of centers in this city that work with LGBTQIA plus folks have gotten pretty good at teaching people how to identify where their cervix is themselves and actually inserting what is essentially a small brush up against it and trying to collect some cells. It is not necessarily as great at collecting tissue as a trained provider is, but it is, in this case, one way to lessen the discomfort, one way that we can still get a necessary screening. The other thing that I think we're going to be hearing a lot more about in the coming years is what about testing for HPV only? HPV is the human papillomavirus. Many people, I would actually say the vast majority of people at some point in their life have come into contact with this virus. When it affects the cervix, it can increase the risk of cervical cancer. So major societies right now are looking at guidelines for how we can do just testing for this virus, which is a much simpler process as far as a swab. More to come. When it comes to breast cancer screening, the major organizations that we rely on, the U.S. Preventative Services Task Force, the American Cancer Society, they do not have the same level of screening guidelines for trans folks as they do for cis folks. That is just a sad reality. So a lot of this is coming from the opinions of experts in the field and from some of these major guides that we all rely on. What we generally say is that for trans men who have not had a complete mastectomy, namely saying that they still have some level of breast tissue or chest tissue, should continue to get mammograms until age 74. Whether it's every year or every 2 years is slightly controversial. We generally say every year now. Those who have had top surgery with that chest tissue being removed should get a chest wall examination from a provider. They don't really say how often. And I generally ask folks to notice, although we don't do a lot of chest self-exams anymore, if folks notice any changes, they should let us know right away. For trans women who either have some degree of breast tissue or who have been on hormone therapy for 5 or more years, should consider getting a mammogram. Namely because estrogen promotes the growth of chest tissue that has some of those breast glandular cells. Those cells, not because of the hormones, but those cells, because they exist, can theoretically develop breast or chest cancer. Yeah. So I'm reading one of these comments here, and I hope it's okay that I'm doing that. That I really appreciate folks sharing their experiences here. And I want to say, I usually say this at the beginning of this talk, but we started late. I recognize that I am a cis gay white man giving this talk. So I appreciate the expertise from those who are living this experience. And if I'm saying anything that doesn't match with your lived experience, stop me and tell me, please. But I really appreciate some of these concerns being there are many reasons why, as things go on and as people age, hormone therapy or medical therapy in general may need to be adjusted. I tell my patients all the time, and I pick random kind of based on their health status. I just saw somebody in the hospital who's 89 and their health is in pretty tough straits right now. And I said, the same medicines that were helpful to you 10, 15, 20 years ago may be different now. So we are certainly open to adjusting. And so further questions. My sister and my mother have had breast cancer. Does that have a higher risk of breast cancer as a transgender woman? That is actually a very, very good question. Some of that depends on the specific types of breast cancer that one's sister and mother have had. Namely, if they are associated with what we call the breast cancer or BRCA gene, BRCA. Theoretically, the answer is yes, if only slightly at baseline. If they have had BRCA gene testing. So I would ask about that and consider testing if you've had multiple first-degree relatives with chest cancer. You should be asking about that. So they did not have the BRCA gene, so it is a much lower risk. But as a transgender person, trans woman who has been on hormone therapy, if it's been greater than 5 years, I would talk to your provider about getting a mammogram. I would like a little post-op trans woman who has not touched a hormone for 20 years. I think the question there is about screening. And so the answer is, if you're not actively on hormones, these guidelines technically do not apply. Now, one other thing that I want to point out is the idea of prostate cancer screening. Prostate cancer screening, as you may have heard from a previous talk we gave a few weeks ago, has been very controversial in general in medicine. And the reason for that is our prostate cancer screening method is often via a blood test, which can have false positives and false negatives, meaning that blood test can be elevated when folks have just prostate enlargement, so non-cancer. It can be low and miss a prostate cancer, so it is not a perfect test. I'll start with saying that. But when folks, even for trans women who have had gender-affirming surgery, the prostate is left intact, usually. You'll see a diagram here showing the neovagina with the prostate here still being next to the bladder. It's essentially not a necessary thing to remove it and can actually change some sexual function if surgeons do. So the idea for many, many years was that, well, if somebody is on estrogen therapy, doesn't that mean you're at a lower risk for developing cancer of the prostate? The reality is we don't have enough data to say yes or no. Screening for prostate cancer is still an option for folks who have a prostate, including trans women. Can be discussed with providers. Depending on age factors, I say 40, 45, or 50. And what that means is we should really be talking about that depending on family history. If folks have had a first-degree relative with prostate cancer, I might start screening earlier. The other thing that I caution folks about now, and there are age guidelines, generally we stop prostate cancer screening around age 75, or at least stop routinely discussing it quite as much. The idea being that most prostate cancers discovered after that age are not as clinically significant. What does that mean? That means that most folks who find a prostate cancer after age 75 are likely going to die of something that is not prostate cancer at some point. The thing that I always caution people about, so when I'm talking to trans women about prostate health in general, is that a diagnosis of prostate cancer can really affect sexual health. Meaning, if we start messing around with the prostate from procedures or removal, that can affect function for anyone, including trans women. And in some cases, the ability to continue hormone therapy depending on the specific type. Yeah, so couple of points. So we see a couple of comments here on what people's general approach should be as far as managing hormone levels. Now, that is a little bit different when we're talking about feminizing versus masculinizing hormone therapy. So for feminizing hormone therapy, the reality is that there is not a great way to predict what someone's estrogen levels should be. We're essentially bringing folks to a level where they are feeling good, not having side effects, not having the toxicities of our therapies, and having desired body changes. There isn't, many folks in this world who are doing gender affirming care don't even check the estrogen levels on a regular basis. That's a little bit different for masculinizing therapy, where we aim for testosterone levels that are in the usual cis male range. And that changes based on age. So I can adjust my dosing sometimes based on age. But again, we are also targeting that as providers really to effect, meaning to what people see, what people feel. Oops. Bone density screening. I saw somebody in the chat mention osteoporosis. As a geriatrician, I care a lot about bone density. So guidelines from the University of California at San Francisco recommend bone density screening starting at age 65 for all transgender patients. Why? They are essentially saying that folks who have been on hormones, we essentially do not have enough data to say we recommend for this specific subset. Now, they also say that the risk of harm from getting what we call a DEXA scan, it looks like this, is pretty darn low. So a DEXA scan is not like an MRI. It's not a CAT scan. It's not something where your whole body is in a scary donut. It is essentially you lie down on a flat plate with walls slightly raised up, and they will run an X-ray machine by a variety of parts of the body. And they will look at the bone density, normal bone looking like this, osteoporosis or bone thinning looking like this. Now, for trans folks in particular who have had gonadectomy, so who have had orchiectomy, hysterectomy, or ovaries removed and have not been on hormone therapy for at least 5 years, should also be undergoing screening regardless of age. The idea behind that being that the hormone fluctuations in the absence of some of those organs can increase the risk of osteoporosis. So again, if you have not talked about this with your provider, I encourage you to do so. So I will get back to some of the comments that are kind of coming in. I don't want to show them all. I know I've accidentally opened a few of them on the screen. I apologize for that. So I do want to go into a little bit about long-term care, talk about some specific aspects of concerns here, talk about advanced care planning, and then I'll get back to some of those questions. Now, this, again, speaking as a cisgender, white, gay man, I can say it's kind of obvious to me and kind of obvious to folks who may be in this group that trans older adults may not feel comfortable, welcomed, or affirmed in long-term care settings. It's pretty obvious. In one study, 10% of people surveyed actually reported that staff did not or refused to call them by their appropriate name and gender, which is terrifying. There is this concern about living as authentic selves, the idea of being forced back into the closet, the idea of having to wear clothing that does not fit with lived experience. There's also this idea of what are other people in the place going to treat me like? It's not just the providers and staff, but it's who else am I with? So these have been really big concerns over the years. Now, this was just last year. This was a news article about a 78-year-old trans woman who was, I believe this was up in Maine, and was having a lot of trouble finding a bed in a rehab facility after discharge. And the reason that they were given is that their hormones were a barrier to placement in this rehab. So that became a whole thing and started another movement, which we are now continuing. There are, unfortunately, not as many states that actually protect against housing discrimination, including in these long-term care settings based on gender identity, including Pennsylvania, which does not have explicit protections, unfortunately. The green states do. The one teal, this kind of lighter green or sage green state, Utah, has only housing discrimination, not housing and public accommodation. So scary that 27 states still have this. Scary to see some of the legislation that's coming out from many places. So what are the things that we're trying to do from a legislative side? There is a need for state and federal level protections. That goes without saying. There is this idea that mandatory education for LGBTQIA plus older adults in care facilities with funding. That's always the big part. It's easy to say you have to do this. It's another thing to say you have to do this. Here's how you do it. Addition of LGBTQIA plus inclusive efforts to area agencies on aging. This is one area that Philadelphia is actually really doing well in right now. The Philadelphia Corporation for Aging actually has an LGBTQIA plus task force that meets every other month. I'm part of that, so that's been really exciting. The other thing that we are working on within my center is this idea of how do we create these affirming settings in post-acute and long-term care. So we actually have an affiliated facility that we're working really closely with to develop some of this content and hopefully share it. Now, one last section, and then I'll leave some time for questions, commentary, whatever. Preparing for serious illness and end of life. In addition to being a geriatrician, I'm also a palliative care doctor. I am currently on our palliative care inpatient service. Palliative care is a realm of medicine that works with folks who have serious illness and possibly even life-limiting illness. When it comes to talking about trans folks, there are some unique issues that we really need to focus on more so than anyone else, honestly. The number one that I would say is the need for surrogate decision makers. I always hope that every single one of my patients is able to tell me their choices, tell me their preferences, tell me about themselves, to be an active participant in care. The reality is that as some diseases progress, that is not always the case. So sometimes we need to rely on the networks. If our trans patients are single or unpartnered, does not have children or regular contact with their biologic family, this is especially important because the state of Pennsylvania does it pretty traditionally based on who we contact next. So that can be blood family members, parents, siblings, children, whoever, which brings up the occasional, and I've seen this happen in the hospital, issues of respect for gender identity, whether it's dead naming, use of inappropriate pronouns, use of the desire for a patient to be dressed in a way that's not congruent with their gender identity. And again, this idea of feeling forced back into the closet as you age or as disease processes advance. So this need for having a surrogate decision maker for naming a specific person who knows wishes well is incredibly important. As I said here, state surrogacy or these next of kin laws is often based on biologic family. Unmarried partners or families of choice are often excluded unless it is specifically documented. Next month, we're doing a talk on advanced care planning. I'm going to bring with me to that talk a bunch of paperwork that you do not need a lawyer to do this. We have documents that, as long as they are signed by each person and witnessed by another, are applied here in Pennsylvania. Now, we also need to think for all of our patients, and especially trans folks, about protection for post-mortem care. What happens after one dies? How is their body presented? How are any memorials naming them or identifying them? And there are specific ways that we can make that happen. So this is the Pennsylvania Advanced Healthcare Directive form. If you are feeling particularly motivated to do this, you can pull it up right online and fill it out. It does not take a very long time to do. It's tough to talk about. Nobody likes talking about these things, but it's really important. Part one is the medical decision maker. That is the part that's most important to me and to many of my colleagues here. Part two allows you to make some choices about healthcare decisions in certain situations. The challenge with part two is that those situations are very black and white, and the reality of healthcare is most of healthcare lives in the gray. So part one, that medical decision maker, incredibly important. So to summarize, trans older adults have experienced real challenges with healthcare. We're trying to change that. We're trying to pay more attention. There are no set age limits on gender affirming therapy. We need to be better, and we are working at being better at offering relevant screenings to our trans older adults and empowering people to bring those up with their care providers, while also thinking about how do we make the system itself better. This is not some Pollyanna talk. I cannot promise that I'm going to be perfect and fix everything by tomorrow. But I think talking to folks about how to ensure their wishes are honored is very important too. So, couple of questions here. What else needs to be checked in folks who are transgender? That's a really good question. So I think that when I think about caring for folks who are trans, I say that you all should get, they should get the same screenings that anyone else should. Things like checking cholesterol, checking liver and kidney function, checking for diabetes with that hemoglobin A1C, where that helps us get an idea. A question. Let's assume I'm unconscious and brought into an ER. Is there any advantage that the doctor know that I am transgender? That is a very, very good question. And the reality is yes and no. Yes, in that some processes are different based on gender assigned at birth. That they are relatively few and far between as far as risk factors for certain procedures or interventions. The reality, if we're really taking it to that level and saying you're unconscious, brought into an ER and end up in the ICU, like some of the patients I've seen earlier today, it's not going to matter all that much in some ways. So the answer is yes and no. And I'm sorry I keep giving those unsatisfying answers. Should older transgender folks start taking specific vitamins or minerals? Vitamins and minerals are both a wonderful thing and the bane of my existence as a geriatrician, because everyone thinks they need more than they do or takes things that are not necessarily recommended. I do tend to recommend that folks consider a multivitamin. They are not going to generally be harmful. The other thing that I encourage folks to, of course, talk to your doctor before starting anything. If you are finding that balance, mobility, and falls are an issue, we often supplement vitamin D to prevent the risk of fracture. So I want to stop here. I do have to run to clinic in about 2 minutes, but I wanted to see if anybody else has any questions. I'm going to take a look through the chat now that I'm not sharing the screen. And again, as always, I really want to thank folks for their participation. It makes these talks fun and hopefully informative for everyone. Thank you so much, and I hope you have a lovely day. It's a lot nicer out there than we all expected.
Thank you.